Hi, Dr. Brian Koffman, a retired family doctor and a CLL patient myself, and the co-founder, chief medical officer, and the executive vice president of the nonprofit CLL Society. And today I'm going to present an abstract from the European Hematology Association's annual Congress in 2022 that I think will be of interest to CLL and SLL patients. The official title was Outcomes Following Treatment with a Covalent BTK and BCL2 Inhibitors Among Patients with Chronic Lymphocytic Leukemia, Small Lymphocytic Lymphoma, a real-world study of a large U.S. database. In the way of introduction, some see CLL, SLL as a solved problem. But unfortunately, we know better. This abstract from the European Hematology Association, or EHA's annual Congress, reinforces one of the greatest unsolved problems. What happens when treatment with a covalent BTK or Bruton tyrosine kinase and BCL2 inhibitor? What happens after that? This is sometimes called double refractory, or I like the term double exposed, because what it's really talking about is patients who've seen both classes of medications, and the meds may work, but the patient may not be able to tolerate them, or there may be another reason they can't go back on them. And this is one of the great unmet needs that the CLL Society is actively promoting be researched. Covalent is a form of irreversible binding, and the original Bruton tyrosine kinase inhibitors, such as ibrutinib and acalabrutinib, and the only approved B-cell lymphoma T inhibitor, BCL2 inhibitor, venetoclax, have revolutionized the care and significantly improved outcomes for patients with CLL or SLL. These agents work amazingly well, but they are palliative. They are not curative. And eventually, most patients will need to be treated again. So what were the results? 339 patients, age 66 on average, with 7 out of 10 being male, met eligibility criteria to be studied. Please note that this was a retrospective review. We know that these patients were exposed to both classes of drugs, but there's other details that we don't know. Of these 339, 215 could be evaluated because they stopped both drugs. We don't know why they stopped. We don't know if it was progression or intolerance or Richter's or remission, but we do know that 7.1% or 24 of them developed Richter's transformation. So what happened to those 215 patients? 47 patients, or 21.9%, died before receiving any subsequent therapy. A little more than half, 116, did receive subsequent therapy, and 52, or almost a quarter, were alive without any subsequent therapy. Here's some of the results that I want you to listen to carefully. The median time from discontinuation of whatever was the last drug that was used, whether it was the BCL2 inhibitor like venetoclax, or whether it was the ibrutinib or acalabrutinib, to the immediate next thing that happened, and those things that I'm talking about are transformation to Richter's, or death, or discontinuing the next line of therapy, was only 4.6 months. Among those who did receive subsequent therapy, the most common immediate next line of therapy usually included venetoclax retreatment with or without another agent. That was used in 61.2% of patients, or an anti-CD20 antibody, such as rituximab or obinutuzumab, with or without other agents, and that was used in a similar 62.9%. Fewer patients, only 12.1%, used a PI3 kinase inhibitor or an additional BTK inhibitor that covalently bound, like 16.4%. The median duration, in other words, how long did the next therapy last for these patients who were double exposed, was less than 5 months. Worse, among the 215 who had discontinued both of these therapies, the median overall survival was only 14.1 months. So how do we conclude? Double exposed patients with CLL, SLL don't do well, as proved by these rather grim statistics on time to the next treatment discontinuation. In other words, how long does it take till they start and finish the next therapy? Duration of that subsequent therapy, and their overall survival. The authors conclude, and we wholeheartedly agree, that there remains a need for more effective therapies for patients with CLL, SLL after progression on covalently binding BTK inhibitors and BCL2-1s. We have a link to the actual EHA abstract, Outcomes Following Treatment with a Covalent BTK and BCL2 Inhibitor Among Patients with Chronic Lymphocytic Leukemia, CLL, Small Lymphocytic Lymphoma, SLL, a real-world study of a large U.S. database. We also have the older data from ASH in 2021, if you want to look at that on the website. We have our work cut out ahead of us, but with new molecules and synergistic combinations being developed and trialed, there is reason for optimism. But the deal is not done. CLL remains an unsolved problem. Thanks for listening. Stay strong. We are all in this together.